Thank you, Mr. Chairman. We're now ready for our next panel, which is our panel for stakeholder comments. Would the following witnesses please join us at the table up front? Jesse Peridon, Luther Cobb, Shelley Schlenker, Sylvia Dominguez, Greg Buchert, Walt Weber, and Jenny Katlov. And while they're coming up, I want to also announce that there will be public comment at the end, and any persons present wishing to say anything and make a comment should sign up with the sergeants. So we have a running list, and you can come up and make a public comment. With that, I'll turn to our stakeholders.
I think I've got this now. Thank you, Chairman Hernandez, Chairman Bonta, Vice Chair Nguyen, and Vice Chair Mayenshane and the members of the committee for holding this very important oversight hearing. My name is Luther Cobb. I'm a board-certified, self-employed physician practicing general and thoracic surgery in Arcata and Eureka in Humboldt County, and I currently serve as the president of the California Medical Association. For the past 18 years, my wife, who is also a general surgeon, have proudly served this community. Both of us are Stanford Medical School graduates, residency trainees, and former faculty professors at Stanford. And we decided to move from the Bay Area 18 years ago to Northern California for a different way of life and to help people who may not have otherwise access to quality surgical care. A physician in that area was retiring, so we took over his practice at the time. As rural specialists with a significant number of patients on MediCal, we have a unique perspective for you to consider.
Doctor, will you excuse me for just one moment?
Yes.
Out of courtesy for our guests, I just want to let you know that I was inviting sign-ups so that we have an order for comment, but there will be the department will be coming back up after this panel and speaking. So, in interest of giving your legs a rest, you may not want to stay lined up there and make yourself more comfortable, and then we'll call you back up in order. Doctor.
Thank you, sir. I also want to commend this committee and their staff for an excellent background paper that raised a number of key policy and budgetary questions similar to the questions you've been raising this morning. I'm hoping that my experience as a MediCal provider can add some context here. Humboldt County, like many other parts of the state, is designated as a health professional shortage area by the federal government. According to information from the OSHPD, Office of Statewide Health Planning and Development, this county lacks the recommended number of primary care physicians, dentists, and mental health providers, and recently we've actually lost the last of our county mental health provider services. Practically speaking, what this means for patients is longer than average wait times for appointments, limited access to certain types of facility care, and the need to travel long distances. And while those of you who represent rural districts know some of these challenges, the situations that our MediCal patients experience are even more serious. You see, by the time that people get to see me, they're likely to be very sick or in serious need of care to help correct their illness because they haven't been seen in a primary care practice. It may be hundreds of miles to the next physicians who can treat them, and in cases of surgical care in particular, that could be the difference between life and death or a serious disability. We estimate that approximately 57,000 people rely on the MediCal program in our county, 43,000 in a managed care plan, and the rest in a fee-for-service. This equals 42% of the residents in Humboldt County, significantly higher than the state average of 32%. As a rural general surgeon, I've seen countless patients enter my care that could likely have avoided these costly surgical interventions with more timely access to appropriate medical care. People that lose a foot because of a diabetic ulcer when their diabetes hadn't been controlled is a perfect example. Many of these patients have been faced with a delay in receiving care because of the difficulty in finding physician offices that are still able to accept the MediCal patients at the current rates. Primary care physicians, as you know, are being reimbursed roughly $16 for an office visit, and they can't do that and keep their doors open. With payments as low as they are, those of us who treat these patients end up making up the costs on other insured patients, and as those rates decline as well, the pressure becomes even greater. This is critically important, and it could impact other major goals of the Affordable Care Act, such as reducing the growth of healthcare costs and also the emphasis on primary and preventive care, which even as a surgical practitioner I'm strongly in favor of. You've heard from the Department of Healthcare Services earlier who assured you on several occasions that the reimbursement rates are adequate to ensure Medicare beneficiaries have access to care, and monitoring of access is ongoing. But regrettably, those of us here at this table know that this situation is different than the picture painted by the department. I come from the South. We would say bless their hearts. And particularly what you're seeing in your own communities and what you're seeing from your constituents. As our state Medicaid agency, they must adhere to federal laws and regulations to ensure similar access to those which commercially insured patients enjoy, and we're not seeing that. Additionally, as part of the executive branch, they're obligated to support the governor's budget proposal, and it contains no meaningful rate increase. This is why we believe this oversight hearing is so important. We've all heard about the crumbling infrastructure of our roads and bridges and gas pipelines. Well, the infrastructure of medical care is also crumbling. It may be less visible, but it's no less deadly. The over 40,000 members of the California Medical Association would like to commend Senator Hernandez and Assemblymember Bonta for your leadership in authorizing legislation to bring MediCal in line with the other major service government payer, which is Medicare. We believe that passage of this legislation will dramatically improve the program, not only in terms of access, but just as importantly in the quality of care that these patients receive. As your briefing paper points out, Medicare plans are widely accepted by providers and receive high marks for patient satisfaction and quality of care. As physicians, I've committed our lives, my life and our lives and careers to ensuring that patients are well taken care of and have access to care when they need it most. Your commitment today to address these issues is an important step in the right direction for the future of the entire healthcare system in California. We strongly urge all members of these committees to co-author this legislation to deliver on our promise of access for the 12 million Californians who depend on MediCal. These bills will restore recently enacted cuts and move Californians' payment structures to those of Medicare. And thank you for holding this important hearing.
Thank you.
Good morning, chairs and members of the Joint Committee. I'm Shelley Schlenker with Dignity Health, representing our 32 California-based hospitals. First, I wanted to let you know that the patient, Mr. Peridone, was unable to make it today at the last minute, so he won't be testifying. By mission and by law, we treat all individuals who present needing medically necessary care, regardless of their ability to pay. Last year alone, Dignity Health provided $176 million in traditional charity care and a total of $1.97 billion in total community benefit, including the shortfall of Medicare and Medicaid. Dignity Health is the largest private provider of MediCal in the state, providing nearly 10% of all MediCal services. That's about 550,000 inpatient days and more than 1 million outpatient visits. Last year, even after the funds from the provider fee and all the supplemental payments, we lost $712 million from costs, not charges, serving MediCal patients. The successful implementation of the ACA has been a priority for Dignity Health as well as all hospitals in the state. California should be proud of reducing the number of uninsured in our state by 40%. MediCal is an important part of the new coverage, with nearly 1 in 3 Californians participating in the program. But we know that coverage does not mean access. Statewide, hospitals are experiencing a surge in the demand for services by MediCal patients. In particular, nearly 1 million more emergency room visits. Many of these ER visits are for primary care services that could be provided in physician offices or clinics. Dignity Health pulled data from our Sacramento region hospitals comparing emergency room visits for 2013 and 2014. There has been a 58% increase in MediCal patients seeking primary care visits through the emergency room in just that 1 year. That's compared to a 6.3% in all other patients for the same thing, including Medicare and commercial. About 50% of our MediCal emergency room visits are for primary care services. This led us to create a navigator program that you will hear about in a minute. The bottom line from our perspective is that lack of access to primary care services is driving the increase in usage of emergency rooms. Without adequate reimbursements for primary care, patients will continue to seek care in the most expensive setting, hospital emergency rooms. As you know, MediCal provider payments are among the lowest rates in the nation, only paying hospitals about 68% of the actual cost of providing care. That's what led to our $712 million loss last year. These levels are not sustainable. Across all hospitals in California, the losses on MediCal total approximately $5 billion. The underfunding of MediCal results in a cost shift to other payers, which drives up costs for all Californians. We strongly urge support for AB 366 and SB 243, which are a significant step towards addressing the underfunding in MediCal. Thank you.
Thank you.
Good afternoon. So my name is Sylvia Dominguez, and I'm a patient navigator for Sacramento Covered, working out of the Methodist Hospital ER. Basically, what I do there is find primary doctors for patients coming into the ER for primary care services, and also scheduling them an appointment, like a follow-up appointment after their ER visit, to ensure that they get established with a doctor. And that is, however, much easier said than done. MediCal patients are facing two major barriers that I've been able to identify in my work. In obtaining services, primary care services in particular, outside of the ER, and they're the following. One of the major ones is doctors' offices don't have appointments for several weeks or months at a time, so the patients would come to the ER instead because they really can't see their doctor when they call them for several months or weeks. This brings a particular patient to mind that I worked with recently. This patient was believed to have a highly aggressive form of cancer and was unable to see his doctor for several months. So he ended up in the ER, and I assisted him in getting a sooner appointment. The appointment that I made him with his doctor was made a week from the ER visit, and he still had to wait several weeks after that to see a specialist. When I followed up with him after his specialty appointment, he explained since the treatment for his cancer had been so delayed, the doctors were not very optimistic about the outcome of his upcoming surgery. After the patient's surgery, I tried to reach him several times, but I never heard back. The other major issue MediCal patients are facing is there's a very limited amount of providers accepting new MediCal patients. I would like to bring up the fact that the doctors list MediCal provides new patients with, in my opinion, is about 80% outdated. A very recent example of this is Mr. Paradon, who was supposed to be here today. This patient shared with me that he had multiple health conditions and that he'd been struggling quite a bit to find a doctor. He shared he called over 15 providers listed on the list of MediCal providers that MediCal had mailed to him, and again, none of them were taking new patients. So it was then that he decided to come to the ER, and I was able to help him find a provider in his area. And as you know, because of this, hundreds, if not thousands, of MediCal patients end up in our ERs every year. And to that, I just want to leave you with a comment that a doctor's office shared with me that I thought was really impactful in regards to this. When I called them to try to schedule an appointment for a patient, they shared that they didn't accept MediCal any longer. And when I asked them why, they said that they had actually framed a check that they received from MediCal for $1 for rendering services to a MediCal patient. And to them, that was going to serve as a reminder as to why they would not accept MediCal. Thank you.
Thank you.
Thank you, Chair Bonton, Chair Hernandez. I'm Dr. Greg Buchert. I'm the President and CEO for California Health and Wellness. And you've heard a lot about MediCal. You've heard a lot about the fee-for-service program, and I want to bring a health plan perspective. And so I'd like to introduce California Health and Wellness. We're the newest MediCal managed care plan in the state, and we serve an exclusive rural market at this point. We serve over 170,000 individuals in 19 counties across the state. And I come with a frontline perspective of the view between fee-for-service and managed care because the communities that we serve are new to the managed care environment. And I'd like to provide a couple of brief points on distinction on access to managed care and then a brief note about the rates in managed care. The first point of distinction is the whole issue around access and quality. in a managed care plan as opposed to fee-for-service, and that the managed care plans are held accountable for our performance through system requirements and measures that don't exist in fee-for-service. Specifically, you've heard that there's contracts, there's regulations, and statutes that require that the MediCal plans adhere to a number of standards that include physician-to-member ratios, geographic access standards, appointment availability, and then we're also measured on quality. You've talked about the CAP surveys. There's also the HEDIS indicators. It's interesting that there's talking about the monitoring that we report to both DHCS and DMHC, and with regard to those types of standards, and just regarding the access standards that we have to submit quarterly, we've reported our standards 3 times in the last 6 months. And so it's something that they actually are aggressively monitoring. The other interesting thing is that not only do they receive reports, but they report those publicly in the MediCal Managed Care dashboard that's available for everybody in the state to see. And so we do serve as a single point of accountability for our members and consumers. And we provide our services, and we contract with 800 PCPs, nearly 3,000 specialists, 43 hospitals, and over 1,000 ancillary providers in these rural areas. Secondly, given our rural areas and the services that they need, it brings some interesting challenges. And we look at it as our mission to provide access and actually to increase access. And, in a managed care environment, we're able to address the issues of the communities that, you've seen the beautiful vistas of Tahoe and Lake Mammoth, or Lake Tahoe and Mammoth and Yosemite. You see the high deserts. You see the country roads. There's not a lot of people in those pictures, but those are the communities that we're currently serving. And so with that, it brings the challenges that we're able to do things such as provide transportation benefit. We're bringing a new benefit that didn't exist previously, that people can get rides to their physicians and get rides to the pharmacies to pick up their prescriptions and get rides back without authorizations, without co-pays, without any kind of share of cost. We spent the better part of a year planning and we'll be rolling out a telehealth strategy to bring specialists virtually into these areas that have been unwilling to move there physically. And we spent a lot of time figuring out why telehealth programs in the past have not been successful. We tried to address all those, and we're looking forward to launching that. The other thing is that we engage in extensive community outreach. We have a high-touch approach. We provided, well over 40 community activities with our, specifically aimed for our members, an additional 30 aimed to with our providers to get out in the communities that we serve and listen, find out what the issues are, what the challenges are, and try to tailor our solutions to the needs of the communities that we're serving. And so, finally, I'd like to just touch on the fact that we look at our job as to increase access to care within the fairly tight financial constraints of the MediCal program as it exists. And with regard to the financing, we are paid a fixed amount, a per member per month charge. We are not paid per service, but we are paid that fixed amount to deliver care. And those rates indeed are set based on our experience on utilization, the amount paid, and for the most part, there's a lot of attempts to match that market experience with the needs of the members. And so that's a quick overview of the managed care perspective, and we're pleased to be a partner in these efforts with you, with the department, and proud to serve the residents of the state that need our services. I'd be happy to respond to any comments at the question period.
Thank you.
Good morning. I'm Dr. Walt Weber. I have a dental practice in Campbell, California, and I'm the president of the California Dental Association. We very much appreciate the committee's holding this hearing today, and we'd like to thank the committee's staff and state auditor staff for all the work they have done to document the critical access problem plaguing the state's DentaCal program. The state audit of the DentalCal program confirms that there are a number of reasons that access to dental care is so poor, and it makes it clear that extremely low reimbursement rates are a significant one. The unsustainable rate structure recognized in the audit simply makes it not feasible for enough providers to treat DentalCal patients in large enough volumes or to participate in the program at all and help the state meet its responsibility for access. As the audit points out, the rates for the 10 most common procedures authorized for payment in DentalCal are only 35% of the national average. To help put that in perspective, for a basic exam, the national average is $44 and the California maximum is $13. For simple filling, the national average is $117. The California maximum is $35. Consequently, the majority of counties in the state do not have an adequate number of DentalCal providers. DentalCal patients unable to access basic preventive dental care in their home county end up traveling hundreds of miles to get emergency dental care. At Highland Hospital in Oakland, for example, over the past 5 years, the number of dental patient visits in the emergency room and the emergency drop-in clinic have almost doubled. Additionally, the number of patients from outside Alameda County compared to patients from Alameda County has increased threefold. In some cases, the only nearby options for surgical procedures that are needed to relieve a patient's pain and infection have waiting lists that are multiple years long. Developmentally disabled patients who must receive dental care under general anesthesia in a hospital have fewer and fewer options left, as hospitals have drastically reduced the hours available for dental services, the most recent example being right here in Sacramento, where the primary hospital for services in the region has cut back substantially this year, citing reimbursement rates. The last rate increase for dental services was 2000, 15 years ago, and when the state adopted the 10% reimbursement rate cut in 2011, all pediatric health services were exempted, but not pediatric dental services. The administration maintained that this would not adversely impact access to care. That prediction was simply not correct. Access to care is steadily declining. We applaud the state for its successful efforts to expand dental coverage to millions of Californians through the ACA's Medicaid expansion and the restoration of adult dental benefits last year. But without substantive action this year, the benefits for these newly enrolled patients will be illusory. The audit, which found that 56% of enrollees aren't getting any dental care, looked only at pediatric patients during 2013, before the expansion took effect and before the restoration of adult dental benefits. So the pent-up demand and increase in number of patients will overwhelm an already broken system without major changes. CDA and our members are strongly committed to delivering dental care to the underserved, and we will go to great lengths to do this. As California dentists currently provide about $400 million every year in pro bono, uncompensated care in addition to services for DentalCal patients, we will always uphold this commitment. Many of you have visited one of our Foundation's CDA Cares events to see the thousands of patients who will wait in line for hours, even days, to be treated. The next one is March 27th and 28th, right here in Sacramento at Cal Expo, and you're all invited to come and see the need. But this is a charity event. This is not a system of care. We believe the state can do better than having a Medicaid program that ranks at the bottom of the nation, and that rate increases will have to be part of any real solution. The state has made a promise to the enrollees, and it needs to uphold its obligation to deliver real access to care. Thank you.
Thank you.
Good morning, Mr. Chairman and members. I am Jenny Catlove with the Children's Partnership. Today I'll be focusing on dental access issues, not only because it's the most chronic health condition among children, but also because we can see it as reflective of the broader challenges California needs to address regarding access to medical care more generally for children enrolled in MediCal. Thank you for addressing the MediCal dental program today. In our view, the recent audit report of MediCal's dental program is one of the singular most important reports completed in recent years and merits continued serious attention by the legislature. We now have the opportunity and momentum to address the long-standing problem of inadequate access to dental care for children in MediCal. The audit report confirms what advocates and community providers have known for a long time, that children enrolled in MediCal are not receiving the dental care they need. With more than half of California's children enrolled in MediCal, it is time to explore real solutions to this appalling gap. The consequence of this neglect is that children suffer. It accounts for persistent pain, trouble eating and sleeping, missed school days, and expensive emergency room visits for preventable dental problems. It also costs taxpayers money related to unnecessary emergency room visits. We support the legislature in requiring the department to analyze and report on specific steps it will take to mitigate this crisis. And we support the recommendations of the audit, including analyzing reimbursement rates. I want to focus on a few critical steps that the legislature and department should consider. First, as been discussed throughout the morning, the department should develop an accurate measure of dental provider network adequacy in the MediCal program. This should include looking at the number of available providers to treat certain subpopulations of children, those populations that traditionally go without needed care, particularly young children and children with special health care needs. The department should look at smaller regions within counties, knowing that county-based data do not always tell the whole story. And the department should do a better job of looking at the number of new and current MediCal enrolled patients a provider treats and the time it takes families to get to appointments and receive care. And then, working with stakeholders, identify and implement tangible solutions to address these gaps, in addition to increasing rates. Additionally, the time has come to explore alternatives to traditional office-based dental care if children are to be well served. We recommend the state invest in the successful virtual dental home to bring dental care to children in schools and Head Start sites. The virtual dental home has been rigorously evaluated and has been proven to be a cost-effective and safe way to bring high-quality dental care to children and others who may otherwise go without needed care. The legislature and administration have already invested in the success of this model through legislation last year. Now it is time to identify a way to ensure this system can reach a critical mass and expand. The department should also invest in making sure younger children receive dental care recommended. Early preventative dental care results in better overall health, and well-being over a lifespan. Yet young children enrolled in MediCal receive dental services at disproportionately low rates. We are pleased the department has begun to look at this population through its outreach efforts, but if there are not enough of the right providers to serve this population, outreach efforts will not work. Moreover, critical to improving outcomes for this population is making sure they are receiving community-based preventative care, family education, and care coordination. The state ought to invest in what truly makes a difference for this population, which could include raising reimbursement rates for providers who see this population, or raising rates for particular services that impact this population, such as preventative services. This could also mean incentivizing community-based providers, promotoras, home visitors, and community workers to work with the dental team to make sure children are getting needed services. For example, the preventative service rule under the Affordable Care Act could allow for MediCal reimbursement for cost-effective ways to provide preventative dental services, as well as other preventative health services in the community, and we encourage the state to adopt this mechanism. We would like to explore these and other options with you further. Again, we are pleased to see that the department is taking steps toward filling the dental care gap for children. However, it is critical that the department engage stakeholders in a meaningful way in developing and implementing strategies to address the dental care needs of these children. We often have direct contact with families or contact with community providers who see families on a day-to-day basis. We should be partners in helping the department explore, shape, and implement solutions. Finally, the state's audit of MediCal's dental program provides a model for how MediCal access for children in general can be evaluated. We recommend the legislature consider requiring an audit of the MediCal program to assess children-specific access experience more generally and identify tangible remedies for any gaps identified. More than half of California's children, as I mentioned, are enrolled in MediCal, with a large portion of them coming into the system in the last couple of years, and we do not know how they are faring in terms of access to care. The Children's Partnership looks forward to working with the committee and the department to implement these and other recommendations to make sure MediCal's children get the care they need. Thank you.